My name is Dyfrig Ap Dafydd. I'm a GP in Llangefni and Anglesey. I've been a cluster lead on Anglesey for a few years, and I've recently started as one of the primary care leads for the planned care team. One of our main projects is the Community Health Pathways programme. Now, this is a set of pathways and guidances for GPs across Wales. They're based on up-to-date evidence and guidance. They're written by GPs with the input of senior medical experts. The plan is that a pathway is developed in various health boards and then developed into a national pathway, and that's usually involving the strategic clinical network for a speciality. And when we have a national pathway, those pathways are then localised in each health board so that if there's a particular resource or referral pathway in a locality, you know it's the right one for you. I think long gone are the days of trying to find pathways printed on a piece of paper in your desk or pinned on your wall, or sifting through dozens of different websites or web links, or looking through your emails, or checking posters on the nurse's wall, the reception wall. These are all going to be in one place. They're going to be up to date and localized to your area. Now, you'll be familiar, I think, with the QI programs in general practice, and in particular this year there is a focus on CKD. What we know is that Flozins can make a tremendous difference in CKD. The reduction in cardiovascular events is astounding, and the reduction in end-stage renal failure is very impressive. There is a goal to try and push Flozin use in CKD and in diabetes, because we're seeing similar protective effects in diabetes regardless of what it's doing for HbA1c. So it's talking about reductions of nearly 25% in cardiovascular disease. And so it's part of the national prescribing indicators for this year too. Now, when we look at the pathways, these have been developed by the same team and reviewed by the same team as the team behind the QI programme for this year. And it goes through the various advice. So we do need to be capturing more ACRs in our CKD population. There's various reasons why that's fallen behind, but primarily it was inactivated in QOF, and we haven't had the searches and prompts inside our systems to encourage and remind us to do this, or at least to let us monitor it for ourselves. And the CKD guidance is very good. It talks about the sorts of things we should be monitoring, the sorts of things we should be checking, how we diagnose, monitoring and highlighting. The areas of guidance that we're particularly looking at in the QI project is this sense of optimising cardiorenal protection. So clearly, always, we have to have good control of blood pressure, good control of lipids, good control of diabetes. Diabetes is the main cause of end-stage kidney failure anywhere, but particularly in Wales. And we want to make sure that we're getting ACE inhibitors in where appropriate. ACEs are still incredibly important in cardiorenal protection. They're very impressive reductions in cardiovascular events and very protective for the kidneys. So we need to make sure we're getting our ACE inhibitors. But recent guidance and evidence is pointing us more and more towards making sure that we're managing these high-risk patients better when it comes to preventing deterioration in kidney function and, of course, cardiovascular events, which are linked with death and morbidity. These are things we know we can avoid. We know that the QI wants us to focus on Flozin use in EGFRs 20 to 45 and EGFRs 45 to 90 with either an ACR over 22.6 or with diabetes. It's worth pointing out the QI has slightly different thresholds here, which is focusing on patients with EGFR 45 to 60 with type 2 diabetes or ACR. This is to do with targeting our highest risk group, And it seems very likely that over time we're going to see broadening of this target area. And realistically, most diabetics with an eGFR under 90 will have a Q-risk score of over 10% and would qualify for Flozins regardless. And most patients with an ACR of greater than 22.6 are likely to benefit from Flozin if their eGFR is under 90. So I wouldn't be surprised if that gets loosened over time. One of my particular areas of interest is in developing EMIS-based searches. So you will have the portal that'll show you data, and we will have Audit Plus for this year that'll show us data. And we have written these searches for the renal QI, and we've written searches for the cardiovascular QI. And I actually think it's very useful to expand on this and include our diabetics group into this, and I'll come back to that. So we talk about cardio-renal-metabolic. Part of the reason I've included diabetes is that we don't have searches within our system looking at who's had their 8 processes monitored. And there's searches here that just shows you who's had their 8 processes, who's had 7 but missing 1. That's quite a nice one to see where your practice might need to focus. And it's an aside, this one, but there are diabetic searches in there and searches for diabetic treatment targets. When I look at the QI projects, there's the headline audit search here. Now you'll see that the screen is partly cut off when I'm recording. That's to make sure that you can't see any patient identifiable information, which means you may miss elements that we're showing you when I'm looking at the searches, but I'll try and avoid that. So if I choose the CKD optimization QI and I view those results, it'll give me an audit report. We're looking at numbers in our CKD register, numbers eligible for Flozin, numbers currently taking a Flozin. So I've got 154 eligible, but only 40 at the moment. Now, you can export these searches into a CSV file and then look at that yourself in Excel. And one of the nice things about these searches is that you can also run these with relative run dates. So if you click Advanced Options, you can change the run date. So if I want to see what was my data like at the 1st of April, I can run that, and I'd run the child searches. And then I can do the same if I wanted, weekly or monthly or 3-monthly, and I can export that data myself and see that myself over time. Just if you want to have live data when you're reviewing your PDSA steps and the cycles of change. The other searches on this are searches for patients who perhaps should be coded as CKD but aren't. I've got quite a large one. Now, I know the QI project wants us to focus on Flozins, but the other areas it's suggesting we look at are things like our coding. Are we monitoring ACR as well? So it's only 57 out of my 180 who've had their ACR done. 150 of them have had their UNEs, which is gratifying. Only 130 have had their blood pressure. Only 93 of those target according to their ACR. I'm also looking at ACE eligibility, and of the 66 eligible there, about 40 are on ACEs, which is better than the Flozins, but still lower than I'd like. And then there's things like statin eligibility, and how many taking statin, about half. And I've also got a few searches looking at comorbidities. Part of the reason I've done this is that when I reviewed all this, all the searches and all the data, it was overwhelmingly clear that most of these patients are diabetic or already have established cardiovascular disease or are pre-diabetic or are hypertensive. And the reason I wanted to show that is that we may be a bit anxious about workload, but actually a lot of this is about really optimizing diabetes management and optimizing cardiovascular disease management. There's very little additional work simply in patients with CKD and nothing else, because most patients with CKD already have other pre-existing conditions. And there's a couple of interesting asides on that I'll come back to later on in the video. When you look at the searches we've built, so if I choose the CKD optimization searches, the initial audit showed you where we're up to on this page, it'll show you the target populations. So we might have our groups where the blood pressure amounts to target, our groups where we should consider an ACE. Now, we've excluded patients who've had ACEs before and they've stopped, or who have adverse or declined codes for any medications here. So if it's suggesting an ACE, there's no previous ACE use and there's no adverse reaction coded. For the Flozins, it's excluding type 1 diabetics, it's excluding patients with DKA, and it's excluding patients who've had Flozins before or have a coded adverse reaction to Flozin. So we're trying to really make sure that we're targeting those who look like they've not had an offer before but probably should be. There's the referrals for finerenone, there's the Flozin group, there's the statin group, and then there's searches around those who haven't had an ACR. Now, this group I've included not just the CKD, but those who are likely CKD. And just to sort of expand on that, there's searches looking for those who probably should be coded. So if you did want to look at your coding, you can look at those who are coded on the register. And I mean, you can look as G15A13 coding. It's something that's very important as part of the English contract, or at least has been. I know it's not been part of the Welsh contract, but I think it's useful in order to sort of stratify risk and things. We can look at those who aren't coded, whose latest 2 EGFRs are under 60, with at least 90 days between 2 EGFRs under 60, i.e. they're likely to have CKD. We could add in those who've had 2 or more ACRs over 3, but we're trying to match up to the searches in the portal and Audit Plus, and we're trying to focus on our high-risk populations here. There's the searches looking at eligibility. So this is looking at who is eligible for an ACE and who is currently taking an ACE. The searches for those who've had a blood pressure in the last year and whether they're to target according to ACR. The searches for those who might be eligible for finerenone referrals, and I'll come back to that. There's also searches looking for those who are perhaps already under the renal or the endocrinology team. We're using those when we're looking at chasing patients, because we might have patients where we think, okay, we haven't done an ACR and UNEs and we need to consider this or X, Y, and Z. But if they're already under secondary care, there's a good chance that that's just been done elsewhere. We just haven't had the results sent to us. And then the search is looking at Flozin eligibility and statin eligibility. Search is looking at the monitoring of CKD, so looking at who's had what processes in the last year and who's on what medications. I was slightly upset to see that we still have a few people on anti-inflammatories. And then there's the wider searches for screening that's referred to in the QI. So this is primarily really the diabetics. We do want to make sure that we're screening the diabetics. And if you're doing your 8 processes, then hopefully we are screening for it there. How many of our CKD or likely CKD have had their ACRs? How many of our cardiovascular disease groups have had their ACRs done? Because again, they're likely, they are a group likely to have CKD. Hypertensives who have ACR, and that's where there's an overlap with the other QI. And then other conditions. So this is conditions like your gout or benign prostatic hypertrophy, family history, kidney disease or end-stage renal disease, proteinuria, stones, hydronephrosis, structural abnormalities, peripheral vascular disease. So it's just that if anyone's interested in that screening element, then that's there. We know that the main focus is Flozin and ACRs. You may not necessarily this year look all that hard at screening in other at-risk groups. We might be focusing on really optimizing management of the known at-risk at the moment, which is certainly what we're going to do in my practice. The reason I'm showing you the video is also to show you how we're linking this in to EMIS prompts and templates. So if I choose example patients, so if I say, for example, I want to look at these patients here where it says consider an ACE, I know that'll link to a prompt under template, and I'll show you this example here. So I've opened up this record and you'll see there's a few prompts here. So, I mean, this patient is also diabetic, which is we're going to see that with a lot of these patients. It's pointing out an assurance concern in that there are missing diabetic processes. Now, if I hover over that, you can't see it because it's out the screen. but it tells me that this person's missing a foot check and missing smoking status in the last year. And then it's this prompt we're saying consider ACE inhibitors, and this is because this patient's diabetic with a blood pressure over 130/80. Now, I quite like this indicator. We used to focus on diabetics with ACRs over 3, but ACEs are so cardio-renal protective. It does seem wise to say anyone diabetic with a blood pressure of 130/80 who isn't on ACE should be considered an ACE. And that's part of the QI and part of the guidance here. There are similar prompts for things like considering a statin because this patient's Q-risk score is over 20%. They're diabetic with a Q-risk over 10%. They're hypertensive with a Q-risk over 10%, and their EGFR is under 60, so they really should be on a statin. If I double-click any of these prompts, it will open up the template that we're providing, and this template will show for this patient, hopefully, similar sort of prompts. Now, this opens my cardio-renal metabolic template, and it's pointing out this patient really should be on a statin and isn't. There doesn't appear to be any previous contraindication, declined, or not tolerated code. There's links, anything in blue, if you click, it'll take you to the nice statin guide for the patient. There's the Q-risk2 score. Now, this is using EMIS's inbuilt concepts for Q-risk2, or the ClinRisk concepts for Q-risk2. There was a bit of concern in England when they went to SNOMED around the validity and safety of this Q-risk, which is partly why it was proposed they should stop using it. NICE is very clear in its guidance, where it says, ideally, yes, use Q-risk3, because we are underscoring some people with risk factors, but until there's an embedded system, it seems pragmatic to use Q-risk2. And this is in the latest NICE guidance on cardiovascular disease risk assessment and reduction. And you can see it saying you can use the embedded Q-risk2. We have set ours up so that if your Q-risk2 score is under 10%, but you've had a code of SLE, migraine, severe mental illness, erectile dysfunction, or corticosteroids and atypical antipsychotics, it would encourage you to use Q-risk3 to check to make sure that you aren't underscoring. It's incredibly important whenever you're doing a Q-risk score to record family history, because that'll actually bump up Q-risk much more than factoring in those other risk factors. If I go back to the rest of this template, so this is one where our prompts are saying consider an ACE, consider a statin, and as you scroll down you'll see the total cholesterol is greater than 4, this person really should be on a statin. It has advice on appropriate coding here, so this person should be coded as G3A1 because their EGFR is 52 and their ACR is unrecordable. It's pointing out their EGFR is under 60 with type 2 diabetes. We should be considering a Flozin. Links to leaflets on the Flozin. This is the Betsy Cadwallader leaflet. I think it's quite good. It maybe over-eggs the risks, but it does have a nice little beginning about talking about why these are good for you. Warnings around being cautious of dehydration, thrush, hypoglycemia. The hypoglycemia issue with gliclazide and insulin. If we have a patient in our system where they're on a gliclazide and their HbA1c is under 58 and their EGFR is over 45, the prompts would warn you and say you might want to halve their dose of gliclazide. Likewise with insulin, if their HbA1c is under 58 and their EGFR is over 45, it'll suggest a 20% reduction in insulin for those patients. And that would come up in a prompt. I'll show that later. The leaflet's very handy. It's looking for any previous adverse. If you're not giving and you haven't recorded an adverse, then please do, because then it'll stop prompting you. So if there's an adverse code, it'll stop prompting to say, please give this person, or please consider a Flozin. Links to the pathway. It's worth noting that whenever you get this, if you do download this protocol off me, you will get links to the pathway at the bottom of your alert box. We may get links into the community health pathways inside EMIS, but for now it will be in your prompts box. If you double click on that, it will, well, I'll show you that in a minute because I'll have to close this one down. Or you can click on the link here and it would take you to the guidance for that, for the CKD. In CKD, obviously the focus on, we've got to prevent deterioration. It's linked with cardiovascular disease, early death, and the need for dialysis. We've got to emphasise lifestyle, focus on reducing ACR, good blood pressure control, ACE, Flozins and statins. If this patient did have a KFRE, a kidney failure risk equation score greater than 5%, my prompts would likely generate a thing to say, hey, this person is at high risk. You can still do it for all your patients if you feel you still want to, and that would take you to the risk calculator, and you can do the KFRE. You need their age, their gender, their EGFR and albumin, so it's quite a quick one, that. And then it's got advice for patients and links to things like patient advice on Think Kidneys. I think this is quite a nice little leaflet. There's links to sick day rules advice. There's links to the NICE ACR guidance flow sheet, which I think is very good. And then there's links to the NICE CKD guidance too. All of that has been pulled together in the Community Health Pathways guidance. And then it's got the various prompts here. It's saying this person's Q risk is likely over 10%. You can see it's 38.7, and they don't have a statin. It can pick up that somebody's had an HGV medical, and whilst this person doesn't have glycoside and isn't on insulin, because they've had an HGV medical, it will still say, hey, would you like to give them the DVLA advice for diabetes? And then it's got the diabetic reviews too, which is your 8 processes, the links to the care plans, the NICE flowcharts in diabetes, the links to My Desmond Wales, and the links to the diabetes DES, if people are still using that, which I think we are at the moment. It's got the links to patient education courses. I have to say, this will link to courses in the BETC. We can change that for people if they want. And then it's picking up if there are missing diabetic processes. So this person's foot check, they haven't had a foot check in the last 2 years. And you can see if the assurance concern here was foot checks and smoking. So it will prompt you for a foot check. It'll point out the hypertension annual review. We've not been great at doing annual reviews in hypertension. Part of it has to do with inactivated QOF. It wants a smoking status. It's got links to help me quit. It's got the coding we were using last year for the QI project on supporting healthy behaviours, and link to that QI project if you still want to see that. It's got alcohol. It's got the processes outstanding. It's got the diabetes targets for blood pressure. Now, the target for blood pressure in Wales for diabetes is 140/80. That's in the Welsh Assurance Framework. The NICE guidance is actually 140/90, but I think these things, they were slightly tidied up only a couple of years ago, and the assurance framework, I guess, may adjust accordingly over time. And it's pointing out the blood tests are up to date, so urinase and lipids are up to date. If you had outstanding blood tests or outstanding processes, it would show them here. Now, part of the reason that I have also given the diabetes searches that we use for our assurance framework is because we don't have them in EMIS, and I think we should have them. You can get that information through Audit Plus and the portal, but I like having that live information. It'll tell you which of your diabetics aren't a target for their blood pressure, which should have an ACE, which should have finerenone, which should have Flozin, which should have statin, and who needs an ACR. Now, part of the reason I've done that is because of the big overlap between diabetes and CKD. So I can see that of my CKD patients, around 100 should be on a Flozin. The diabetics, around 200 should be on a Flozin. When I combine the two, it's 260. Now, what that means is around 40% of my CKD patients are already diabetic and would be indicated for Flozin purely because of their diabetes. The slightly unnerving thing for me when I was looking at the data was when I look at some of the comorbidities around CKD and diabetes, and I was looking at the 60, there's 260 patients where we should be considering a Flozin. Now, it'll flag up caution if they are a patient where they're already on insulin or gliclazide, and as I said, if their HbA1c is under 58 and EGFR is over 45. If I choose an example patient, so you can see that, you'll see that in the alerts box here, it is saying consider Flozin, and when I hover over that, it's telling me the diabetic with a Q risk likely over 10%. I should also be considering an ACE because their ACR is over 3 and their blood pressure is over 130/80. It will flag here a little prompt saying caution initiating Flozin because it's suggesting that we should consider reducing dose of gliclazide by 50% because this person's parameters are ones we should watch. So if I look at his latest EGFR, you can see it's over 90, and the latest HbA1c is under 58. So they are somebody who would potentially be at risk of a hypo, and it's just flagging that up for you. If you were to open up the template for this person, it would still carry that sort of prompt or advice into the template as well. So you'll see when I open up the cardiorenal-metabolic template for this patient, it's suggesting that they're, ignore that, they are G1A2, so their ACR is 17, and it's suggesting caution initiating with links to the UK Kidney Association summary recommendations for advice on that if people want to go and see that. So this is, I think it's section 5B. And it's very good. These are excellent recommendations and guidance. It's talking about how this person's diabetic with a raised ACR but no ACE, Q risk over 10% but no Flozin. Again, it's gliclazide, so it's suggesting driving advice for them. Important to make sure that we click and tick to say we've given that advice as well. We know that since QOF went, we've just perhaps been doing some of this work, but not necessarily coding to show that we have done it. And if we haven't ticked a box and coded, we can't prove it. We can say we do it for everyone, but ticking the box definitely shows it has been done. I mean, the other way would be to create a protocol that automatically prints off the information when a patient comes in when they are supposed to be having this guidance, but that's a whole different video, that one. But the point I wanted to make around CKD and diabetic overlaps is that of the CKD patients where they're eligible for a Flozin, where they are CKD without diabetes, I thought it would be interesting to see what was their last HbA1c. I'd expected to see a lot of pre-diabetic patients, or perhaps, have they had it done? And I was a little unnerved to see that only 3 of those 65 have ever had an HbA1c done. So this is one of my first PDSAs is from the data is to pick up on the fact that we are not monitoring HbA1cs in our CKD group. And what I've done is I've changed now my process capture recalls and templates to make sure that if they've got an EGFR under 60, yes, my HCA prompt, this is the template that tells my staff what processes to capture when they come in, will now include an HbA1c for this group. I suspect that if we were to do an HbA1c in this 65, who, because they're eligible for a Flozin, I know it's because they're raised ACR, there is a very high chance that most of those are either diabetic or pre-diabetic. And again, I don't mind if this project helps me to screen for higher risk groups, because we know that if we find the diabetic and manage that diabetic more effectively, then we are going to reduce cardiovascular events, death, end-stage renal disease, and diabetic complications. Now, part of our current situation is we're in a planning stage. We've got the QI project. We're looking at the data. We're looking at, okay, where are we data poor? Where are we missing processes? Have we got particular areas we should be targeting? Now, yes, we've got quite a lot of patients who probably should be considered for a Flozin, and that's in our CKD group and our diabetic group. What's clear from my CKD group that are eligible for Flozin is we need to be bringing those people in for an HbA1c. I think that's a high priority for me. We also need to be chasing ACRs in most of our CKD patients and diabetic groups. I have created a set of searches to sort of focus on where we might want to focus first. So this is catch-up work. Now, quality improvement isn't about an audit and catching up and that's the job done. Quality improvement is about embedding processes in our daily work that make sure that we're managing things effectively. Ideally, you want a process that's easy, that's integrated, that's cheap and effective. If we have a process that's laborious and labor and it takes a lot of time to do, it's unlikely that we'll carry on doing it. So the goal here is to look for what is the easiest way of making sure that we recall effectively, that we capture all the processes we want, and that when those patients are seen, that we make sure that they are being offered the best management, that we're optimizing them most effectively. But what I do have in the meantime is the groups that we might want to consider to target at the moment for catch-up, which I think is a separate issue to QI, but is still a reasonable part of this work. And I've broadly split these into two groups. Some patients have had their processes done and they're ready to go, and we should be considering reviewing these and considering offering Flozins or ACEs or statins or better blood pressure management in these groups, because I'm pulling in the cardiovascular disease group here or the cardiovascular prevention group here too. What we found when I started looking at the consider Flozin group here is that quite a lot of them hadn't actually had their processes done. So it might pick up that they had an eGFR of 53 and an ACR of 25 from, say, 3 years ago. And we might be contacting a patient or reviewing a patient saying, oh, we should be considering a Flozin, only to have the patient say, well, I've not had a test done, or I've not had this done for 3-4 years. Or they could be CKD patients who've never had an HbA1c done. And I think it's important to consider capturing processes where they haven't been done in the first year before putting those patients in front of a clinician. So these are searches for those where they need a process. So for example, if you've got somebody who's eligible for Flozin, but they haven't had an ACR done, which is about 96 of my patients, then I'd be tempted to send them the Healthy IO urine pot and get them tested. If we are doing that, please remember that ACR under 3 in those is fine. If their ACR is over 3, then they will need repeating to get a formal number. It would need repeating anyway. It's just that it's just a feedback from our involvement in that project. 100 of them need blood tests. Now, there is an issue around capacity for blood testing, and I'm not expecting that we get to do all this straight away. Likewise, we've done similar things for who's had ACR ever and not had. The hypertensives, not to target, but no blood pressure in the past 15 months. So these are people with the cardiovascular disease prevention QI. These are people whose blood pressure isn't to target. They haven't had one in 15 months. Some of them just need a blood pressure, but most of them need UNEs. A few of them need ACRs. And similar for those where the blood pressure's been done this year, but it's not to target, have they had their processes? Most of this, hopefully, will be fairly self-intuitive. The clinician review group is the group where I'd suggest we consider how we approach these patients at the moment. So I have about 20 patients where we should be considering an ACE and a Flozin. If I open up one of these as an example, again, you'll see he's diabetic, and it's got my prompt saying that he's got an insurance concern because he's missing his lipids, foot check, and blood pressure. We should be considering a Flozin. We should be considering an ACE. He needs a blood pressure because it's 148 over 105, and it'll tell you the target for him is 140 over 90 because he's got cardiovascular disease, raised HbA1c, EGFR under 90. We should be considering a statin because he's diabetic with a Q-risk over 10% and he's hypertensive with a Q-risk over 10%. If we open up the template for this gentleman, it will tell us again that we should be considering ACE, should be considering a Flozin, they should be considering a statin. It'll look to see if there's any previous adverse codes. The Q-risk 2, Q-risk 3 issue is an interesting one, and I'll come back to that in another video. The G2A1, he's low risk, but so he's not necessarily needing coding for that because he's not G3, but it's just highlighting that, pointing out Q-risk 2 is likely over 10%. There's no statin. Q-risk over 10%. There's no Flozin. And just again, it's got the nice guidance here, sort of where it points out we should be considering Flozins if their Q-risk 2 is over 10%. And then it's got the diabetic reviews and the various links, the foot checks, alcohol, and any other missing processes. So you can see he's had his HbA1c, it's up to date as of November, the UNEs are up to date as of October, but his lipids haven't been done recently. And we found that's quite common, where ACRs and lipids were one of the first, or some of the indicators that went first from QOF. And you can see that the current QOF indicators, or current QOF prompts for us, only look at the blood pressure and foot checks here. So the QOF prompts aren't actually particularly useful for assurance framework, and I think they're almost a year or two behind what we need at the moment. We only have searches in EMIS that will tell you whether your patient's had a blood pressure, HbA1c, and foot check. It's not showing anything about the other 5 processes in diabetes, not showing any prompts for the other 5 processes in diabetes. And we have similar searches for the other groups. So these are the patients where they've had the processes that are necessary to consider these things in the last year. We could consider bringing them in and discussing ACE and Flozin with them now. Likewise, the cardiovascular disease prevention and hypertension group, these are people where we should be considering a statin, either Q-risk over 20% or Q-risk 10 to 20%, depending on where you want to target first. If any of these patients, say if you're on the hypertension register and you probably need to be considered for a statin, but you're also needing a Flozin, they would be in one of the searches here. So these would be consider Flozin plus or minus statin, and it would show in the template for them. Now it's worth being aware, when we're looking at process capture, this is really looking for your UNEs and HbA1c where appropriate, ACR, blood pressure, and lipids. My wider work looks at process capture for absolutely everything in any medications, any enhanced service, any QI, any QOF, and any sort of anything we can possibly think of, and pulls everything into one place. That's a much wider template. So if you were coming in to see one of my staff, it would look at for any of these processes, but also make sure you're not missing other processes. And if anybody is interested in the wider, wants to purchase the wider template that would incorporate all of these things and the wider process capture to make sure that you're not wasting appointments bringing people back in several times, then please do approach me separately for that.